please welcome to the stage Kwaku and Sarah. Well, welcome to the Roche Idea Lab. We're happy to chat today about HCV elimination here in the US and what role the lab plays in that campaign. And I'm happy to have this conversation with Dr. Wheeler, so I'll let her introduce herself and then we can kick this off.
Awesome.
Wheeler.
Thank you. So I'm an associate professor at the University of Pittsburgh, and I'm also medical director for clinical immunopathology at UPMC Hospital. As part of that, I oversee HCV serologic testing for both our pregnant population, our adult population, I guess it wouldn't just be both, it would be all three, and our pediatric population.
Thank you, Dr. Wheeler. So HCV is becoming a public health crisis here in the US. So, and in few sentences, can you tell us what HCV is, who's at risk, and how you can contract it?
Yeah, so HCV is a bloodborne pathogen. So many of us have had our bloodborne pathogens training. So any exposure to blood that has HCV in it is going to be of concern, which also puts our socioeconomically disadvantaged population at risk, particularly those who might be IV drug users. That's going to be of major concern. And then also because of the increasing prevalence, we have a lot of concern for our pregnant population. And so screening has been recommended by the CDC in pregnancy. You can see that the numbers are very high right now with an increase of over 400%. This is becoming much more concern to make sure that we're getting screening happening.
Yeah, so just to touch on that a little bit more, HCV is often considered as a silent epidemic, right? So what are some of the complications of living with HCV? Those are basically, what are the complications of chronic HCV?
Yeah, so one of the things that's difficult about HCV is that with chronic HCV, you may not have symptoms immediately, which highlights the need for screening, but also progression from having a healthy liver. So the liver is an amazing organ and responsible for a ridiculous number of functions in our body. And because of that, as the liver goes from being healthy into fibrosis and cirrhosis with HCV, we start to see a lot more health complications. And unfortunately, that also increases the risk for hepatocellular carcinoma as well.
So how does care look like in the US right now? Are there vaccinations, or what with people living with HCV, what are the options?
So unfortunately for HCV, we do not have vaccinations. So we do, however, have really great antivirals now that can allow for complete cure for many patients. So with complete cure, that does mean that they will still be positive for antibodies because their body has been exposed to it. But thankfully, if we can get people connected to molecular testing, we can figure out what their treatment should be and actually get most of them to cure.
Thank you. So can you walk us through the typical patient journey for an HCV patient, and what are the testing guidelines or algorithm for a typical HCV patient currently here in the US?
Yeah, so many of our patients are caught simply through standard screening. So they have come in, they're having a serology test run. So we're looking for antibodies, their body's response to HCV. If that comes up positive, then they'll need to go back to their physician usually and get a molecular test done so we can determine what their baseline viral load is, as well as understanding their genotype to figure out what appropriate therapy would be for them, and then get them on the appropriate therapy. And then recheck their molecular testing to check what their viral load should be, and see as their viral load resolves to make sure that we've effected cure.
And then looking at the typical patient journey, who is most at risk of HCV, and how does this patient journey differ with the different at-risk population?
Yeah, so unfortunately for our at-risk population, a lot of them are seeking care only through the emergency department. So again, because this is a bloodborne disease, many of our at-risk patients are IV drug users. And because they're only seeking care through the emergency department, there's a lot of loss to follow up. So they get their initial screening test done. They're positive for HCV antibodies, but getting them back to get molecular testing done and to get treatment is definitely an issue. And I believe, and you probably know this a little bit better than me, currently we're capturing only maybe 50% of people with HCV and getting them through to cure. I think that number might be even lower.
Yes, that's a perfect segue into what we have here. So this was a seminal study that was published recently, and you can see as you describe the patient journey, there's a lot of loss to follow up. So currently there are about 3.5 million people estimated to be living with HCV here in the US. And the patient journey that you described, there's a serology testing at the beginning, and only 50% of people living with HCV go ahead to confirm their diagnosis. So right off the bat, you're losing 50% of your population. And then with every cascade in the patient journey, you're losing a huge amount. And then as you can see on here, only 9% of patients get to the end and then receive treatment. And this is extremely sad because the drugs are very potent, they work, and you achieve cure. So there's no reason for us losing this many people to follow up, not even getting them to treatment. So
especially because many of these are people who are identified as having hepatitis C, that we lose them just between the cracks, essentially.
Exactly. So looking at this problem, I mean, we know that this is the biggest problem with HCV. What role can the lab play in solving this problem?
Yeah, I love that question because there is so much that the lab can do. So in HCV and in public health in general, a lot of our issues are in making sure that people get tests where they're getting care, and that there is follow-up in the testing. So making sure we are thoughtful about how we're providing testing, and that we are making sure that the right people are getting the right information around that testing. Because a lot of the gaps that are happening here are in follow-up testing. That means as laboratorians, we actually have the ability to affect change on this in these vulnerable populations.
So just to dive a little bit more deeper into that, right? So the CDC put some certain things in place here in the US to combat the problem. Can you tell us some of the things that they put in place and why they're still lacking currently? And we can move on to some of the future solutions that you think can help address the problem further, yeah?
Yeah, so, well, I guess two major things that I would highlight from CDC are that, one, HCV screening is recommended in all of our pregnant patients. And that is both amazing and a little bit difficult from a laboratory perspective because our pregnant population is a population that has a low level of HCV prevalence overall. So even though our assays are amazing, when we put them into a low prevalence population, we're going to be seeing more false positives. And that is obviously a very difficult test to be positive if you are a pregnant patient. And so we need to be cognizant of that as we are doing our testing and making sure that we are connecting them to some sort of confirmation test or an orthogonal test to make sure that we're not sending out false positives due to the low prevalence. And then the other piece from the CDC is the recommendation that all serologic testing be reflexed to molecular testing automatically. That's a little difficult in most of our labs because that means we either need 2 tubes of blood from every patient, and most of those patients will be negative, and so we don't need that second tube, and it's just going to get thrown away. Unfortunately, hospital-acquired anemia is a thing, and we don't want to be supporting that if we don't have to. But if we're aliquoting the tube, that also poses problems because as soon as we open a tube that we're going to send for molecular testing, we introduce the opportunity for contamination of that tube. And so I do think that a lot of our loss to follow-up is because we don't have a great way to do kind of this automatic reflex to molecular, which is our only other test currently available.
Thank you so much. So essentially what you're describing is the perfect solution, not that there's any such thing, right? It's a solution that can capture the patient one time when they visit the hospital, right? So can you describe how that solution might look like and what could work to solve that specific problem, right?
Yeah, so currently there are really 3 ways that we can look at HCV. So we can look at serology through antibodies. We can look at antigen testing, which is going to look at the proteins created by the virus. And then we can also look at the molecular testing. So we're looking at the actual nucleic acids involved in the virus. So having just the antibody screening, we're looking at the body's response. So that's always going to be a screening test and is a really great first level test for us to look at to increase the prevalence for whatever second test we do. Something like antigen testing is helpful because it's much more amenable to doing quickly, doing close to the patient, and doing for a reasonable cost. So that's also a nice, like, let's bring down our false positivity from low prevalence screening option, not currently available. And then molecular testing as a confirmation test, being able to get that, so perhaps point of care molecular testing or something that could be closer to the patient, again, as a second line. I'm definitely, we have had this conversation. I'm definitely a fan of making sure that we have a screening test and a confirmation test, and making sure that the confirmation test is molecular, but that the screening test, which is going to be in a low prevalence population, is an appropriate screening test.
Yeah, so can we take it a step back and look at the different solutions that you've described? I just realized we didn't describe what aspects of the virus they're testing. So can we step back a little bit and look at antigen testing, molecular testing, and antibody testing? What are we actually testing, and why are they suitable for the things that you just described?
Yeah, so antibody testing or serology is going to be looking at our body's response to the virus, and that everybody's body responds a little bit differently, and so there are always going to be more possibilities for interference in something that is not what we would consider a direct detection for, and because everybody's antibodies are a bit different, there are also other opportunities for interference. When we talk about antigen assays, we're talking about the proteins produced by the virus. And so that's a bit more of a direct detection method, and allows us to utilize a lot of the types of assays that we're used to. And then again, in molecular testing, because we're looking really at the nucleic acid that is within the virus, that is considered a very direct method. But it does require amplification, and amplification is, again, another step where we could have some contamination problems.
Thank you so much. So we have, as I started, HCV is becoming a public health crisis, and there's a huge push nationwide to help get rid of HCV, by 2030.
Yeah.
And we just spoke about the lab's role in that campaign. So give us how the future looks like. What's the outlook, and how, again, can the lab help facilitate that campaign?
Yeah, so we can't treat what we don't know about, so we have to get everybody tested. That's the major place where the lab can help. And a lot of our testing needs to be happening where patients are receiving care. So I am a big proponent of making sure that, if we are only seeing certain populations that are high risk in the emergency department, then we need to be turning around those tests to the emergency department while that patient is still in our emergency department, to make sure we can stop the spread of HCV. Other things that would be, am I allowed to talk about things that I would love to have that are not currently available?
Absolutely.
Yes. Okay. So I would love to see us have more point of care testing for this, so that at least screening is happening where our patients are getting their care, and we can actually be taking the testing out into the community. I feel like we don't do enough of that here, and making sure that as we like to do with A1C or whatever, take it to health fairs, make sure people are getting tested. Once they're tested, then we can start connecting them to treatment, but until they're tested, we can't. And that does mean that we need technologies that are flexible for being able to be done either at point of care or done rapidly. And that's something that there's a bit of a gap right now. In terms of screening, we can screen rapidly, but we don't have a good necessarily second test unless we do kind of orthogonal serologic testing.
I like that. I like what you said. You can't treat what you don't know, right? And with infectious diseases, to get rid of them, you also have to stop the transmission. So, final thoughts: how can testing play a role in just stopping the spread, right? Because you can't eliminate something if it still keeps on spreading. So, just a thought on how testing helps stop spread of all infectious diseases, especially with HCV, which is a bloodborne pathogen.
Yeah, so one of the great things about bloodborne pathogens is that we're not going to spread them simply by walking around. So once you know that you have HCV, you can make sure that you're taking appropriate precautions for yourself and the people you interact with. So I would say knowing that an infection is present means not only that you get treated, but that also that we can start to take the precautions necessary to prevent transmission, which will help bring down continued infection, hopefully by 2030.
Thank you. And we have a lot of lab directors here. So what is your matching order for all colleagues out there? What can they do to help with this campaign?
Yeah, so I would say there are probably two things that we can do: making sure that our turnaround times for the emergency department and our other high-risk populations are appropriate, and getting them answers while they're still there, if at all possible. And sometimes that means that we have some of our infectious disease serology screenings happening overnight, which may not already be what we're doing. And then the second thing I would say is working with our care team that actually provides the interventions to make sure that so there are many kind of electronic alert systems that can make sure that the care team that needs to provide treatment for HCV or provide orders for molecular HCV, molecular testing of HCV, can get that information quickly so that the patients can be connected to care kind of before discharge, if at all possible.
Thank you so much. That concludes the Idea Lab. I'm sure Dr. Wheeler will be hoping to answer some questions if anybody has them.
All right, so great talk. Quick question, and it's in twofold. So the graph that you showed, where we have about 50% of individuals going undiagnosed, what do we do with that population? And also, in a low prevalence setting, are we not toying with our performance characteristics, especially MPV and PPV, in these low prevalent population?
Yeah, really great question. Do you want me to take that first? Do you want to take a first stab?
Take a first step.
Okay. So I think undiagnosed, the first question is, why are they undiagnosed? They haven't been screened. So how do we get more people screened? We try to meet them where they are. So whether that's, I don't know if I want to say everybody coming through our emergency department being screened, but making sure that we are assessing who should be getting kind of high-risk screening when they come through, whether that's through a general practitioner's office, through our emergency department, other things. So that can also be, for us, making sure that we have appropriate order sets. So if there are already order sets that are standardly run in kind of a high-risk population, is HCV something that would be appropriate to add to those? I feel like that's a really great place that we're still underutilizing in the lab. And then your second question
was about PPV. I can take a stab at that.
Yes, go ahead.
So yes, you're absolutely right. In a low prevalence setting, when you're testing, it all depends on the prevalence. Even if you have a 100% sensitive assay, your prevalent brings your test performance down. But I would like to address that question by looking at the prevalence. So in the general population, you're looking at 1 to 3%. In actually patients who inject drugs, that could go all the way up to 53%. So it's not that low prevalent when you come to high risk population. Second, I think Dr. Wheeler touched on it briefly, the sequence of testing, right? So you need to increase your prevalence. So we talked about PCR being the gold standard. In such a population where there's low prevalence, you do the screening first, so with something like an antigen or an antibody test, and then confirm with PCR. So the second sequence, you really increase your prevalence, and that basically complements the assay that you're using to do the confirmation. So the first part of it is it's not really that less prevalent in high-risk populations. And then second, the screening sequence that we're proposing or others are proposing really helps with improving the prevalence before you confirm. And that helps with the loss of follow-up as well.
Thank you very much. So you said only 32% of diagnosed individuals receive treatment. Is the challenge access to treatment or something else?
It's a good question that I'm actually going to kick to you on this.
Yes, so the challenge is multiple-fold, but so far the biggest challenge is just the loss of follow-up. So before you can receive treatment, before you qualify to receive treatment, there's a lot of things that you need to do, which includes testing. So currently, in the US, you screen with an anti-HCV, but that doesn't tell you that you have an active infection. Before that, actually, 30% of people will spontaneously clear their virus, right? So you need to, the practice in the US before was, well, if 30% of patients are going to actively clear, why should we treat them? But that was when the treatment also has some consequences, right? The treatment had very bad side effects. With the new direct-acting antivirals, they're very tolerable. Like they don't have a lot of side effects. But the problem has been improving the testing sequence to confirm patients who have active infection, because the drugs are very expensive, so you don't want to treat only people that will benefit from it. So right off the bat, it's just the way we screen for people and then identify people with active infection is what we're losing significant amount of people to. And there are other things that is gradually improving. So for instance, one of the biggest barriers was for you to be able to get on treatment, you have to prove sobriety. So you shouldn't be taking alcohol. You have to show that there's some damage in your liver, which didn't really make a lot of sense, because as you showed in the earlier graph, by the time you get to that stage, it's probably too late, and there are no vaccines, and transplant is the only solution. So looking at all these barriers, I mean, testing is a huge component, but there are also some barriers to it, which I think AASLD, which is the guidelines that look at the treatment guidelines, is taking steps to remove some of these barriers. Gilead is the one that makes the drug, and they're also taking steps to reduce the costs. But the testing still remains a constant. I think that's where labs come in, because I think if we can reduce the barriers to testing and confirm people early on, then we could get them to the treatment pipeline and hopefully increase that 16 and then 9%. And then one last thing is, even the 16% of patients that enter treatment, as you can see here, only 9% go ahead to finish the regimen. It's a 12-week regimen. So this is also education that we and then also clinicians need to do to help people get through the whole process. And so if the treatment is going to take 12 weeks, and you can imagine the testing is going to also take another 12 weeks to get through the whole sequence, then we're putting barriers in front of these patients every step of the way, which is not helping. So.
I know we're at time, but I'd like to just add slightly to this, which is, I think this highlights why we need to be working with our clinical partners. So we clearly have a lot of people who are going undiagnosed, and then once they're diagnosed, we have a lot of people that are not continuing to full treatment. And if we can work with our partners who are actually prescribing the treatment and following through on the treatment, we can make sure that the attrition that happens between diagnosis and treatment, we can close that gap a little bit more if we work with them. From prescribed to full 12 weeks is something we have less work on, but I think it's a great opportunity for us to be working with our clinical colleagues in that as well. It's a really great question. I don't know how much of the problem is access to treatment, and it's a valid question.
Thank you for a nice discussion. So this question goes to you, Dr. Teria. So what is Roche doing in this approach in trying to eradicate HCV infections by 2030? I'd like to hear some of the ideas that are being discussed.
Thank you. So Roche is an IVD company, right? So I think the biggest problem here I see is testing and then removing the barriers to confirming patients early on. So Roche is approaching that in different ways. In medical affairs, we're educating patients, making sure they are aware of this silent epidemic. In terms of Roche company itself, we are developing solutions that directly addresses this problem. So the ideal solution is to have patients come in once or just a single blood draw. You could screen and then confirm, at least for a group of patients. And I think that would drastically reduce that gap that you see where the chronic and actively actively confirmed patients. So if you could have one test that can screen and also confirm, and there's so many ways you could do that. One of them will be a point of care PCR test. The other one could be even a cheaper version could be an antigen testing. And I say we are looking at those two approaches.